Today on Primary Care, the Human Papillomavirus, or HPV. It's highly communicable and does not discriminate with age, race, or gender.
The HPV virus can cause cervical, vaginal, vulvar, rectal, or head and neck cancer in both men and women.
Hello and welcome to today's edition of Primary Care. I'm your host, Dr. Lonnie Joe. The human papillomavirus, better known as HPV, is so common that according to the Centers for Disease Control, almost everyone who is sexually active will get it. That's a problem because HPV can cause several types of cancers, including cervical and rectal. It's particularly dangerous for Black women who die sooner and more often than women of any other race. Here to help us better understand what HPV is Dr. Cheryl Gibson Fountain. Dr. Gibson is Associate Professor of Obstetrician and Gynecologist at Oakland University William Beaumont School of Medicine and also attending physician at Beaumont Health System. She is also the former president of the Michigan State Medical Society, and not to mention she is also the first Black female serving in that capacity. Dr. Gibson, welcome to the show.
Thank you very much.
It's about time we track you down and get you here. Tell us about HPV and its importance.
So HPV is the human papillomavirus, and it infects most men and women throughout their lifetime.
Men and women.
Men and women. And most of the time, in most men and women, the HPV virus clears itself. However, we don't know which people are going to be cleared of the HPV virus. So it's important that we do screenings and then diagnosis and treatment. The HPV virus can cause cervical, vaginal, vulvar, rectal, or head and neck cancer in both men and women.
So we see more and more of it.
Yes.
It's been around a while, but it seems to be taking off.
Right, and so the problem with the HPV virus is that ultimately it causes cervical cancer, and cervical cancer is on the rise, and cervical cancer is on the rise and highest in African American women. We know back in 1951, we all have heard of the story of Henrietta Lacks. Henrietta Lacks died of cervical cancer back in 1951, and it wasn't until 1981 that we actually diagnosed that it was the actual human papillomavirus that caused her death. Unfortunately, her cells, as we know, the HeLa cells, Henrietta Lacks died, but her cells lived on, and we have used her cells.
Yeah, they were preserved.
That were preserved, yes. And taken from her, by the way, without her permission or her family's permission, and utilized for so many other things, like to treat polio and treating all different types of cancers now with HIV and AIDS. But I just start there to say that she died of cervical cancer, and cervical cancer is on the rise because of some of the ways that we are not screening women, and in particular African American women, for cervical cancer. The screening should actually occur, and we have what's called the United States Preventative Services Task Force, which gives recommendations or preferred screening intervals for patients, but they're not our patients. They're not, and those screening techniques and the screening intervals are actually causing the incidence of cervical cancer to rise in our population here in Detroit.
Are we not getting to them?
So what's happening is the screening guidelines, for instance, say do not do screening or cervical pap smears in anyone under age 21 or anyone over age 65, which is just ludicrous from our standpoint because of the fact that we know that women over age 65, and we have plenty of studies to show that. So the guidelines that the United States Preventative Services Task Force has created, while based in science, are not based in the science of taking care of our population, and therefore there's a rise with increasing these intervals of screening. There's a rise in cervical cancer here in our city and in our Black women.
We have to be very expressive about a disease like this, and we have to talk about transmission. So for our viewing audience, how is this disease spread?
So HPV is spread through contact. So HPV, the human papillomavirus, can cause the various cancers, so cervical, vaginal, vulvar, rectal, and oral, as well as warts, genital warts in both men and women. It can be spread by genital sexual contact, but it can also just be spread by contact, skin-to-skin contact. So that's one thing that people really want to be aware.
A lot of people don't know that, Dr.
Yes, yes. So it's not just penile vaginal intercourse, but just touching of the bodies, you can transmit the virus from person to person, which is why the human papillomavirus vaccine, or the Gardasil, is so important. So we must take the stigma away from the human papillomavirus. You know, you get on a plane, you get the cold virus. You have sex, you get the human papillomavirus. It's something that happens, and we just have to get away from the stigma, and therefore I think we would have more young girls and men and young boys vaccinated. At this point in time, the HPV vaccine should be given from age 9 all the way up to age 45. The old recommendation was 9 to 26, but more recently the recommendation has changed to include 26-year-olds up to age 45. And there's a series of vaccines that should be given at the initial vaccine, 2 months and 6 months. However, you know, it's been shown that, you know, just getting the first vaccine would be sufficient.
Right, that's more than a start at this point. What symptoms should patients be experiencing with this virus?
So that's a really excellent point. In men and young boys, there are no symptoms. So that's how it is able to be spread. And in women, you know, with the exception of being able to see genital warts on, you know, either the young boy or the man, or genital warts on the vulvar area of the woman, you don't really no, which is why the Pap smear is so important in women, and the Pap smear then is sent to the lab, and the pathologist puts the cells on a slide and then looks at the slide, and if the HPV vaccine is detected, then the physicians do what's called a colposcopy, where we actually look at the cervix with a magnifying lens, and then we take a biopsy of any cells that have what's called the HPV effect.
So this is not necessarily a news flash.
No.
It's an old story.
Old story.
That we haven't told properly.
Right, yes, yes. And just so important, like I say, that we actually do the screenings. You know, the Pap smear was created back in back about 70 years ago, when Dr. Papanicolaou actually utilized his wife's cervix. He obtained about 1,000 different specimens from her her cervix. Back in those days, you know, we didn't have our IRBs or any of those things. But so the Pap smear was invented back then. To this day, that still is the most implementable way of detecting cervical cancer, and should be done in everybody age 21 on until they go to be with the Lord, or if they're sexually active under age 21. So I know that you know, is not the recommendations from the United States Preventative Services Task Force, but when we're talking about our patients, we have to look at that patient that's right in front of us, and actually, you know, make our decisions based on who our patients are.
This is the reality of face-to-face treatment.
Yes, yes.
The other reality is that we're up against a break, Dr. Gibson. We'll be right back with more discussion on the human papillomavirus with Dr. Cheryl Gibson Fountain.
It's been said that knowledge is power. Knowing what's normal for you and knowing the warning signs of gynecologic cancers. That's powerful, maybe even life-saving. Find out more. It's been said that knowledge is power. So know this: you can prevent cervical cancer by getting screened. How's that for powerful? Take control of your health.
Welcome back. We're here with Dr. Cheryl Gibson Fountain, Associate Professor of Obstetrician and Gynecology at the Oakland University William Beaumont School of Medicine and attending physician at Beaumont Health System. Let's talk about some of the subtypes of this virus. As you know, one particular subtype found in black women poses a particular problem problem in terms of treatment.
Right. So once again, the vaccine is the mainstay of preventing the HPV virus from causing cervical cancer or any of the other cancers in young men and young women. We know in African American women, HPV type 35 is seen 3 times more prevalent in African American women than European women as the cause of cervical cancer. However, the HPV type 35 is not covered by the new non-valent vaccine, nor was it covered by the previous HPV types. So, because of that, it's so important that we continue to do, screenings to find out if there's any type of cervical cancer present. And the other issue that I have with some of the newer recommendations that have come from the United States Preventative Services Task Force is not having to have a gynecologic exam or a pap smear every year. So that's very problematic.
Yeah, that's confusing to the general population also.
Yes, it is.
We've gone through this in some other disease states,
Yes.
new recommendations on mammography, those
right,
types of things. So,
right.
so tell us what the new recommendations that are controversial. Okay, tell us about it.
So once again, and you're right, it's very, very confusing, and patients hear these recommendations and then they don't come in. I have most recently had a patient that was over 65 diagnosed with cervical cancer. I've had a patient that was over 65 with that had a previous hysterectomy, and women with hysterectomies are told that you don't need to have a pap smear, and she had diagnosed with adenocarcinoma of the vagina. So it's just very, very problematic, and we have to get the word out that our patients are different, and it's just so important that people, that primary care physicians realize that the reason that these United States Preventative Services Task Force preferences were made is to kind of contain, it's a monetary situation where they want
to save money.
Exactly, yeah. Trying to save money at the expense of now the rates and rising in cervical cancer.
So initially there may appear to be a savings, but
right.
in the long haul,
right.
It costs you more because there's a late diagnosis.
Right. The information that they're using is looking at things from a population health standpoint, and we know that the science is sound with regard to the recommendations that they are making for a certain segment of the population. However, African American women, like I said, with regard to the HPV 35, have different HPV types, and so those things should be taken into consideration when deciding how often to screen.
You know, we kind of focused erroneously years ago, as far as this disease state was concerned, just on women and young ladies.
Right.
Talk to us about young men and, their particular risk and their
right.
role in this disease.
Right, so we're talking about what kind of symptoms. How do you know that you have the HPV virus? You really don't, and so it's so important that we vaccinate the young men as well. They can transmit the virus to young women, but also they can get the HPV virus themselves, from oral sex, anal sex. They can get the head and neck cancers and the rectal cancers, and we're seeing them in young boys, young teenage boys, and young men and older men, and it's just so important that the HPV vaccine be given to them as well.
In the primary care setting, are we testing properly? We test for a lot of other things. We got to push on Hep C now for, the boomers. Are we testing properly for this particular disease across the spectrum of patients?
So I would say the answer to that is no, and unfortunately it just speaks to some of the things that I was alluding to. We're actually going backwards because we're not testing, newer recommendations are saying test less and less and less. So for instance, the recommendation that the United States Preventative Services Task Force states is no one under age 21 should be tested for HPV. Well, that's just ludicrous. They focus on, between 21 and 26, and then no one over age 65 should be tested, and we see a rise in the cervical cancer rates. So no, we're not testing properly. We're actually, going backward.
So there seems to be some age discrimination on both ends of the scale here. If you're getting to be too old, we're saying that you don't need testing for various things, including HPV.
Right,
and
right.
we're recommending not testing people on the younger spectrum of the age scale who possibly are at risk more than anybody now in a sexually active society.
Exactly, and so, the assumption with older women, over age 65 is they're not sexually active. I don't know where that came from, but, that's the actual assumption. So once a woman's 65, she's no longer sexually active, you no longer have to test her for the HPV. The thought behind not testing for 21 years and younger is if you find the vaccine in somebody less than 21 years old, what are you going to do? You're not going to do much about it, but that's just like burying your head in the sand. You want to know if the virus is present, and it needs to be treated. Your method of treatment might be a little bit different in a younger person, but we know that there's from the time a person generally gets the HPV virus, which happens around 13, 14, could happen earlier if there's earlier sexual activity. It takes about 8 years for it to be manifest, which is why are seeing these younger women with the cervical dysplasia, carcinoma in situ, which is just such a shame.
Barriers to getting treatment outside of access to traditional things that we look at. Are we seeing cooperation from the insurance industry on something like this? We know that the product is available. Can you mention, where we are in terms of costs and what patients are going through to actually get the treatment from an insurance standpoint of view?
So let me just, this is really interesting, and I just had a conversation with one of the VPs at Blue Cross Blue Shield who brought to my attention that they are seeing a rise in cervical cancer claims. And her frustration is that not only is she seeing a rise in cervical cancer claims, but wants to know why. So she too called for what you were speaking about, that we actually have got to straighten out what is going on with the recommendations. So you have the United States Preventative Services Task Force with one set of recommendations, and then you have the American College of Obstetrician and Gynecologist, the American Cancer Society with the other set of recommendations that I've been talking about, which is basically just screen everyone age 21 on, or under 21 if they're sexually active. So the insurance companies, to my surprise, are very concerned and want to actually cover the screenings and then cover the diagnostic methods and then cover treatment if we do have to send our patient on to a gynecologic oncologist.
That's good news. Dr. Gibson, we're going to go to a break. We'll be right back with more on human papillomavirus.
You listen when your body says, "I'm tired," or "I'm hungry." What if your body said something else might be wrong? Gynecologic cancers, cervical, ovarian, and uterine cancers have symptoms, so pay attention. If your body says something may be wrong, please listen. If it goes on for 2 weeks, see a doctor. It may be nothing, but find out, learn the symptoms, get the inside knowledge about gynecologic cancers.
We're back with Dr. Cheryl Gibson Fountain, Associate Professor of Obstetrics and Gynecology at Oakland University William Beaumont School of Medicine. Dr. Gibson, it is a devastating thing to face a teenager, child, with this diagnosis. How does this affect not only the patient, but the family also? There has to be some interesting dynamics there.
Yes, so there are really interesting dynamics. First off, trying to get the family or the parents to allow their child to get the human papillomavirus vaccine. The recommendations and what I believe is that young boys and young girls should get the vaccine as early as age 9. So the conversation that is had is that, well, if they get this vaccine, isn't this going to make them more sexually active, wanting to desire sex more? And as been pointing out, boys and girls are having sex anyway. So the point is to prevent the cancer. And it's such a devastating thing to bring in a young person with their parents and tell them that oh, by the way, I need to refer you to a GYN oncologist because your daughter has been diagnosed with carcinoma in situ. So it's such a devastating thing. And to know then that something could have been done to prevent that, and these days we have the vaccine that should be given to everyone from age 9 through age 45 is, you know, it's really breaks my heart to know that this could have been prevented. And like I say, especially in our community, and that just speaks to the whole access piece of how certain people are not even offered the vaccine when they go, you know, see their primary care docs. And so it's just so incumbent upon us to get the word out to our community that no, this is not causing them to be more sexually promiscuous. This is preventing cancer.
So, in addition to all of this, you know, we've got the social stigmata
Yes.
Associated with this disease. To me, it's a matter of educating the general public as well as the patient.
Exactly.
How are we doing along the educational lines with this disease state?
Not so well. There's just a stigma, and especially in our African American community, that you're promiscuous, having too much sex. You get on a plane, you catch the cold virus. You have sex, you get the HPV virus. It's pretty common, and we just have to get over that stigma and then have people screened and get their screening cervical pap smear, and then if there's anything positive on that pap smear, have a biopsy taken from that abnormal appearing tissue, and then refer that person on to our GYN oncologist.
You know, just this week in the national media, we've gone from the tray on the airplane, the tray table on the airplane being the most infective thing that we come in contact in society, to the headrest, saying that it contains more variety and concentration of germs than anything else that we come in. Although sometimes when I look at these keyboards that we deal with, they're everywhere, you know, from the library to your home to the hospital, you know, they say, wait a minute, what's this crud doing down there? I mean, it's got to be an area that we expose the public to, but we're still, with this in mind, we're still not educating properly.
We're not. And that's a challenge, and how do we get that word out? And, you know, shows such as this are a blessing to get the message out to people, you know, as to what the facts are, and, you know, to protect themselves and their families.
So here again, we're back to some reoccurring themes. Education for patients, education for providers, education for the lay public, and we're still not getting the message out properly concerning this disease state.
And what parent wouldn't want to prevent their child from developing cancer later on in life? And so that's kind of the message that we need to get out.
Touch base on the role of the primary care provider in this disease state in particular.
So the role of the primary provider would then be to use the United States Preventative Services Task Force guidelines as just that, guidelines, but take into account the patient that you have in front of you. So if you are taking care of an African American patient, realize that patient has a higher risk of developing cervical cancer and a higher risk of dying from cervical cancer, because women are still dying of cervical cancer, which is just, you know, it's just appalling, because no one should die of cervical cancer. So what I would say to a primary care physician is, even though we know we got population health basis for these recommendations that come out of the United States Preventative Services Task Force, that they don't apply to African Americans, and the fact that HPV 35 is not in the vaccine, you still need to do the pap smears to make the diagnosis. So I would just employ our primary care physicians to really do annual pap smears on all our patients.
Dr. Gibson, I always like to ask about what's on the horizon. You know, we got anything in the pipeline, any Star Wars approach to what we can expect in the future as far as the treatment of HPV?
Well, treatment for me would be to just make sure that very early on I refer my patient with a diagnosis to the GYN oncologist, and they are the people that would actually do the treatment. Regarding diagnosis, you know, we have just screening for the HPV virus alone without doing the pap smear. However, I still feel that performing the pap smear is the most implementable way of detecting the HPV virus and then treating if necessary.
Cheryl, thank you so much for joining us on the show today. It's certainly been a pleasure.
It's been a blessing
We'll
to
do
be
this
here with
again.
you. Thank you so much.
We've been talking with Dr. Cheryl Gibson Fountain, Associate Professor of Obstetrician and Gynecology at Oakland University William Beaumont School of Medicine and attending physician at Beaumont Health System. Don't go anywhere. We'll be right back with some final thoughts after this.
It's been said that knowledge is power. Knowing what's normal for you and knowing the warning signs of gynecologic cancers. That's powerful, maybe even life-saving. Find out more. It's been said that knowledge is power. So know this. You can prevent cervical cancer by getting screened. How's that for powerful? Take control of your health.
Final thoughts. The human papillomavirus, HPV, is not new. It's an old disease state. What's new is our approach to it, which needs to be stepped up. We need to be more active about how we educate not only patients and families, but also the community and healthcare providers. This disease state should not fester with one individual in terms of treatment. It's something that we all have an obligation to, and we can do better. For Primary Care, I'm Dr. Lonnie Joe.